Colon cancer is a major health problem in the United States and in Nevada. It's the second leading cause of death from cancer, despite the fact that it is preventable. One of the reasons why so many people die in the USA and in Nevada every year from colon cancer is because they don't get their screens, their colon cancer screening. And there's many reasons for this. But one of the biggest reasons may be the choices we offer our patients. You see, many, if not most, physicians offer colonoscopy as the only choice for screening for a patient. However, many patients simply will not have a colonoscopy when it's time to have one. Today we're going to talk about the burden of colon cancer. We're going to talk about current options that are approved for colon cancer screening, and we're going to suggest some choices that you might suggest to your patients that will increase screening rates and potentially save the lives of countless Nevadans. This PowerPoint presentation is a part of the Nevada Primary Care Physicians Toolkit. It's a project sponsored by the Nevada Colon Cancer Partnership and supported by a generous grant from the CDC. It's an adaptation of a much larger toolkit created by the American Cancer Society and referenced in your booklet. This toolkit is comprised of 3 items: this PowerPoint presentation, a booklet on the 5 essentials of an effective colon cancer screening program in the primary care office, and a list of multiple tools such as form letters, templates, decision aids, log sheets that you might use to make your office more effective in colon cancer screening. So to begin with, a few words about the burden of colon cancer. Colon cancer is the second most common cause of death from cancer in men and women, behind lung cancer. In 2007, there were over 1,000 cases of colon cancer in Nevada and over 150,000 new cases of colon cancer across the United States. Almost 500 people in Nevada died from colon cancer, and over 50,000 died across the country. Fewer Latinos, American Indians, and blacks are screened, and there's a higher death rate among African Americans in colon cancer. So this next slide is for reference. We're going to be talking in a few moments about some studies that suggest why colonoscopy is not perfect, why we miss polyps, and you may have seen these in your own literature, and they talk about the right colon and the left colon. So I'll be using those same terms in future slides. I want to point out to you, so we're all talking about the same thing. The right colon begins in the ascending colon at the cecum. It goes up past the hepatic flexure, up here to the splenic flexure. And the left colon extends on down to the rectum. And the right colon has slightly more colon cancers than the left colon does. So this next slide is very important in our discussion because it talks about how you go from a normal colon to a benign polyp and finally into a cancer. And of course, if we remove the polyp before it becomes a cancer, we can prevent cancer. And that's the point of colon cancer screening. Now, there's many different types of polyps, and it's important to know those that we care about and those that we don't care about. There's hyperplastic polyps that have minimal or no colon cancer potential. And then there's adenomatous polyps, like the one you saw on the last screen. We think that almost all polyps begin as adenomatous polyps. And they're the typical ones that we see that look like a large cauliflower. And up until about 10 years ago, maybe in some places 5 years ago, those were what we thought polyps basically were. But then, in the last 10 years, this concept of a flat polyp has surfaced. It began in Japan, and this is probably the reason why we're not perfect. And this is an important polyp to get to know. These are flat serrated adenomas. And I suspect that you can't tell from looking at this very easily that that's a polyp because it looks like flat lining of normal colon. And that's the same thought that I had when I saw it. I wasn't sure if it was a polyp either, but if you look at it very carefully, you can pick out subtle differences with a colonoscope. Not very visible on this image, but that's actually a polyp. And you can imagine how hard it would be to find this polyp and how easy it would be to miss it. Now, I do want to point out that this polyp is magnified, but it's probably about the size of between a nickel and a dime. And that's going to be important in a little while when we talk about smaller polyps and their potential for becoming a cancer. Now you can you can kind of wonder, the big cauliflower polyp that we saw, you can imagine how easy it would be to remove, put a snare around it, burn it off. But how do you grab a little flat polyp? Well, that's a challenge too, because there's nothing really to grab. So with these flat polyps, we actually take a needle and we'll inject some saline under the polyp, putting it on a bump. And then we're able to grab that bump and then burn it off. When I took that off and sent it off to the pathologist, it was actually a small cancer. Some more facts about colon cancer that are important to know. We've already alluded to this. All colon cancers are believed to begin in benign polyps. 25% more, I should say 25% or more people will have a precancerous colon polyp. And screening colonoscopy with removal of all polyps, we think, can reduce mortality by 60 or 70%. Now, the reason I say 60 to 70%, and you'll hear numbers that really vary even over a wider range, is because perfect randomized control studies haven't been done yet. So most of our estimates are based upon other indirect studies. But this is our best guess for most experts today. Now, this next slide is one of the studies recently done that's raised concern that asked the question, how effective is colonoscopy? This was done in Canada, and it basically is a case control study, meaning they took a group of patients who had a colonoscopy and compared them with a similar group who didn't have a colonoscopy. And they looked at what appeared to be the reduction in mortality over a period of time. And if you looked at all cancers, there was about a 38% reduction in mortality for people who had colonoscopies. So if you break it down by which side of the colon the cancers were on the right side, you can barely see this bar because there was really no reduction in mortality in right-sided cancers. And all the reduction occurred in the left side, where there was almost a 70% reduction. So that gave us a lot of concern. Are we missing polyps in the right side of the colon? Those flat polyps that I showed you, those are primarily right-sided polyps. And so this made us question, is doing a full colonoscopy really reasonable? If you can't find polyps on the right side, perhaps we shouldn't even be doing a full colonoscopy. Now, those of us who do colonoscopies, we take off polyps all the time on the right side of the colon, including flat polyps, and many times there's cancers. So we know we're having impact. So we question this study. And when you look at the details of this study done in Canada, there only 31% of colonoscopies are performed by gastroenterologists, and the rest are performed by surgeons or primary care doctors. We know that you have to be very busy doing colonoscopies, perhaps do 400 or 500 a year, if you're going to be able to detect and safely remove those flat polyps. So it was the thinking of many people that perhaps one of the reasons this study was so poor was because most of the colonoscopies done in Canada are not done by gastroenterologists. Well, here's another study that came out of Great Britain, and this was more recent, and this has given us some reassurance. If you want to look at the reduction of the incidence of cancer, it's almost 80%. Left-sided was better, almost 90%, but even right-sided we saw 55% reduction in mortality. We know right side's going to be a challenge, but clearly we made a difference here. And I think when we have more studies coming out in the future, I think we'll find evidence that colonoscopy does benefit both sides of the colon. So benefits of screening. Now, when we talk today about choices that you're going to offer your patient for screening, we're going to talk about preventing cancer, and we're going to talk about detecting cancer. And colon cancer is one of those cancers that even detecting a cancer, even finding a cancer is beneficial. I'm sure a lot of your patients have told you, I don't even want to know if I have a cancer, it's just going to kill me anyway. But the real truth is, with colon cancer, if it's local, it's almost 90% curable. And even if it's regional, it's almost 70% curable. Only when colon cancer has distant metastasis is it futile. So even detecting colon cancer can be very beneficial for your patients. So is colonoscopy cost effective? That's a very important topic today. And as you'll see, a colonoscopy every 10 years compares very favorably with the cost of mammography for screening for breast cancer. How are we doing? Well, if you look over the last 15 years, between at least 1990 and 2005, we've had a reduction in colon cancer mortality by about 30% in both men and women. So colon cancer screening seems to be working, but we have a long way to go. It's often been said that Nevada is at the bottom of every good list and the top of every bad list. Well, here we rank number 50. We're at the top. Unfortunately, this is a bad list. This is the ranking of colon cancer mortality in 2004 compared with the other states. We consistently rank poorly, and one of the reasons for that is we consistently screen poorly. This is the screening that's occurred across the United States and in Nevada from 2004 to 2008. Now, these bars would show that in 2004, about half of Americans got screened, and in 2008, about 60% got screened. This doesn't mean they had colonoscopies. This counts a stool test or any scope, either a colonoscopy or a flexible sigmoidoscopy. And this blue bar is Nevada. You can see that in all these time periods, we lagged the country, and we're always one of the most poorly screened. If you look at trends, this shows it a little bit better. Between 2004 and 2006, we were making some gain on the country, but these lines are marginally wider, and we're losing the battle again in colon cancer screening. So many reasons why people don't get screened. One of the reasons, of course, is if they don't have any insurance and they can't afford to be screened. Insurance status and screening is very important. If you look at the uninsured, less than 40% get screened, compared to people who have insurance, almost 70%. And this number is very important. In Nevada in 2006, almost 24% of Nevadans had no insurance, compared with the national average of 19. We know today, with the economy, the stress that we're all under, that uninsurance rate is much higher. And so this screening rate is going to be even worse and a bigger challenge for us. All colonoscopies are not created equal. You saw an example in Canada where it appears to us that a large number of polyps in the right colon may not have been seen. We've developed quality parameters that we think every gastroenterologist should be measuring in their office when they do colonoscopies. Withdrawal time is very important. In this study of withdrawal time, the number of polyps that were encountered during colonoscopy ranged from 16 to a high of 40%, depending upon how long the colonoscopist took to withdraw the scope, with a withdrawal time of 6 to 8 minutes as finding more polyps. So it's been recommended that we track our withdrawal times. And we all should be doing this. As we do colonoscopies, we should be measuring how long it takes us to withdraw the colonoscope on every patient. And we should be tracking that, and our average withdrawal time should be 6 to 8 minutes. Our polyp miss rate is very important. We should be tracking polyps so that if we're only finding 10% polyps over a period of time, something we're doing wrong. So we should be tracking that. We should find at least 25% polyps in men and 15% in women. Polyp preparation is really important. You saw how flat that polyp was on the serrated adenoma. Very easy to miss. If the right side of the colon is not well cleaned during the bowel preparation, we're not going to see those. And in the old days, which really was only a few years ago, we would give a gallon of a preparation at night. And we would give all the preparation at night. And the next day we'd do the exam, and that right side of the colon was often not very well cleaned. And I think that was part of the problem that we were having. Now we do a split prep. I'll show you an example of this in a moment. But number one, it's a smaller volume prep, so it's half the volume of the old prep. But we give half late at night and half early morning. We now get perfectly clear preps most of the time, which gives us a much better opportunity of finding and removal of those dangerous flat polyps. Clearly, the training and experience of the endoscopist is very important. Any of you who have tried to get your patients to deliver a stool for blood know what this is like. That's not quite the stool sample we had in mind. And it brings up the point that all stool tests are not equal. There was a stool test that many of us trained with, the guaiac test. It was a chemical reaction. These are fecal occult blood tests. And now we have a new test. It's called the FIT test, or the immunochemical fecal occult blood test, compared with the guaiac fecal occult blood test. And they're not the same. The guaiac test was a chemical reaction that could be interfered with by eating red meat. Certain vitamins and other things might affect the accuracy of that test. This new test, the immunochemical test, is actually a reaction for human globin. So you don't have to restrict the patient's diet. It's much more accurate. You're much less likely to have false positives or false negatives. It's also one specimen versus 3 specimens. It's easier to collect, and patients are more likely to return these for testing. It ends up having a much greater accuracy compared with the old Hemoccult. 75 to 85% of patients who have a cancer will be picked up with one single FIT test. And as we talked about earlier on that prior slide, if you find a cancer, remember, many of them are curable. So an additional very important point about stool hemocults is the rectal exam done for Hemoccult in the office. Many of us over the years have used this very important tool to find out if a patient has blood in their stool. The point is that when you study this particular technique, it's not very accurate. It's only 5% sensitivity and 9% specificity, meaning that only 5% of cancers or large polyps do you pick up with a stool Hemoccult done in the office, and only 9% specificity. That means that almost 90% of the time that you have a positive stool Hemoccult, you won't find anything. So the patient gets put through a whole barrage of testing unnecessarily. So this is not a very accurate test, and it should be discouraged. And indeed, in our last guidelines that came out in 2008, it specifically stated that this is not appropriate for screening. So we shouldn't be doing it. Yet a recent study shows that as many as 30% of physicians still use this as their primary means of screening. And I'm not suggesting you shouldn't do Hemoccults in your office, because there are reasons to do it, clinical reasons to do it, but it should not be your method of screening your patients. Even though they're there and you've got the opportunity and it's easy, and many patients will not comply with screening, you can't let you or they think that you have screened them if you do one of these stool tests. Let's talk a little bit about flexible sigmoidoscopy just briefly, because I'm going to talk about it in more detail as a screening option. So you remember now our diagram about the colon. Flexible sigmoidoscope goes through about 1/3 of the colon, sometimes as much as a half. Now, flexible sigmoidoscopy as a screening tool, it's not done very often anymore for many reasons. One of the most important reasons is our sterilization concerns. In the past, many primary care doctors did these in their office, but now we know to sterilize these scopes is difficult and expensive. The sterilizing equipment for endoscopy can cost $6,000 for one unit. It just isn't feasible for primary care doctors to be doing flexible sigmoidoscopies in their office, and they're just not done anymore. It's an inefficient use of office resources. Patients don't get sedated, and it's actually more uncomfortable than a colonoscopy. Patients don't like it, and they won't come back for another one. And now a few words about CT colonoscopy. This is in the press quite a bit. Now this is a CT image that's been modified a little bit, and there is a small polyp that you can see there. Probably you can't see it, but there is one there. When they modify this more with software, the radiologist is actually able to travel through the inside of the colon, and here's that same polyp, much more visible. And it's quite a feat how they're able to find those small polyps. But is it appropriate for us to be using for screening? Well, it requires a bowel prep. Now, it is safer than colonoscopy, and it doesn't require sedation. It's got very good accuracy for larger polyps, 10 millimeters. As you recall, the polyp that I found that was flat was probably only about 6 or 7 millimeters in diameter, and it was flat. So it's less accurate for smaller polyps, and its accuracy for flat polyps can't be as good as a colonoscopy. And it requires a colonoscopy and polypectomy if the polyp is greater or equal to 6 millimeters. Now again, they use 6, but sometimes we have cancers that are smaller than 6 millimeters. The price is $1,000 to $1,500. Medicare doesn't cover colonoscopy, or I should say virtual colonoscopy, except for the cases when a real colonoscopy is either contraindicated or can't be completed. And there's a lot of concern nowadays about the risk of radiation. So for all of these reasons, people have questioned the value and the role of colonoscopy done by CT scan in these patients. And then the final question is, what do you do with these polyps that you leave behind, especially, like I mentioned a moment ago, if the polyp's larger than 6 millimeters, the patient should have a colonoscopy and a polypectomy. Well, how comfortable will the patient feel leaving behind one small polyp? Or even worse, what if that patient has 3 or 4 small polyps? They would not have colonoscopy. If you look at how we approach patients who have colonoscopy and polypectomy, if we remove 4 polyps and they're all adenomas, even if they're 5 millimeters, we know that that's a high-risk patient for cancer, and we're going to screen them more carefully. So how to use this and whether we should use this tool is very controversial. Friendlier preps. We talked about the split prep, taking half the prep at night, half in the morning, and these patient-friendly preps that are reduced volume. This is the gallon prep that we were using routinely just as recently as 5 years ago, and this is one of the new half-volume preps. There are other half-volume preps out there, but you can see that it's easier for the patient. And then this prep here, a patient would take half in the evening and half in the morning. So it even reduces the burden more on the patient, and it also gives us a better prep and a much cleaner colon. Split preps are better, as I've already alluded to. Half the bowel prep given in the evening and half in the morning, 5 hours before. A much better prep, better tolerated, and a cleaner colon. And we're going to be able to do a better job preventing cancer. So at this point, I want to talk about the different colon cancer screening options that are out there. A few years ago, we had renewed guidelines for colon cancer screening. In 2008, we had 3 different sets of guidelines that came out. They all talked about these same 6 options, and they're all similar. Colonoscopy every 10 years, stools for occult blood every year, a flexible sigmoidoscopy every 5 years, a double contrast barium enema every 5 years. Now, I'm not talking today in this presentation about a double contrast barium enema. It is rarely done, but it is an option to be done every 5 years. CT colonography every 5 years, or fecal DNA, and they really haven't established an interval for that. Finally, the bottom 5 all need colonoscopy if positive. So in 2008, we had 3 sets of guidelines that came out. The Multi-Society Task Force, the U.S. Preventative Services Task Force, and the ACG. And those of us who do this a lot think that having 3 sets of guidelines and 6 different options make this very confusing for patients and very confusing for physicians. How do you choose which of these options for your patients? And I think that that may be one of the reasons why we have trouble getting patients screened. They're not quite certain what to do. When you look at these options, and I'll talk about it more in a moment, of those 6 options and these 3 guidelines, if you look at the guidelines, they all break down those options and ask the question, does this test prevent cancer or detect cancer? And all these guidelines, although there were differences between them, I should say 2 of the guidelines, favor cancer prevention over cancer detection. So try to make sense of these options. Again, we can look at these tests as a test that will prevent cancer or one that will detect cancer. Those that prevent cancer will detect cancer and also those polyps that we can remove. So because it can find a small polyp, we can remove it, it can prevent cancer. The other tests primarily detect cancer. They're not designed to detect and remove polyps. They're designed to find cancer at an early stage. So the screening options, those that prevent cancer, are colonoscopy, sigmoidoscopy, double contrast barium enema, and virtual colonoscopy. Those are all capable of finding those small polyps that we can then take off and remove. And those that primarily detect cancer are the stool fit test and the stool DNA. Now, if tests that can prevent cancer are preferred, why don't we just recommend those? Why do you have everything else? Well, there's many reasons. What we've discovered is patients have many different preferences. Patients don't like invasive procedures. They prefer something done in the privacy of their own home. There is no true gold standard. Although many of us believe colonoscopy is better than these other tests, we really haven't proven it. So to force somebody to get a colonoscopy is difficult. Colonoscopies have a higher chance of complication. And some of these require a bowel prep, and patients just simply don't like that. So because of all those reasons, it's felt that when the societies that are designed to make recommendations for us, they don't just recommend one choice. They give us a whole myriad of choices. In this case, they give us 6 choices. But maybe 6 is too many, and maybe that doesn't make sense for us. This is a very busy slide, and I'm going to try to make this as easy as I can and just point out the most important parts of it. Now, this is the Multi-Task Force Guidelines. This is the U.S. Preventative Services Task Force, and then this is the ACG. Now, this set of guidelines and this committee is a committee of internists, radiologists, gastroenterologists, and the American Cancer Society, so it's very broad-based. The U.S. Preventative Services Task Force, that's the task force that you'll remember was involved in the mammography controversy a few years ago. But this is the task force that Medicare uses. So this is the task force, and their recommendations will determine what Medicare is going to approve. Then the ACG is a task force of gastroenterologists. Now, on this side, you've got stools for occult blood, stool for DNA, flex sig, barium enema, etc. And this looks at the sensitivities and the specificities. I'm going to go through here just real quickly. In the case of the multi-task force, they basically said yes to everything. The multi-task force says all 6 options are options, and they don't really make much distinction. Now, the U.S. Preventative Services Task Force made it a little easier. They recommended just 3 options: either the stools for occult blood, that short scope, the flex sig with stools for occult blood, or colonoscopy. They did not recommend barium enema, CT colonography, or stool DNA. And then finally, the ACG took it a little step further, and although they have some nuances to what they recommend, they basically took these tests and they broke them into cancer prevention and cancer detection. They recommended the immunochemical fecal occult blood, the FIT test, as the preferred test for cancer detection, and the colonoscopy as the preferred test for cancer prevention. So all those guidelines are different. What should we do in Nevada? It is a little bit confusing. I think if you really think about it, it gets a little simpler. Most of these 6 options are not available for us to use. Virtual colonoscopy and stool DNA are not covered for colon cancer screening by most insurance companies. And they're not really widely available for routine use in Nevada for that reason. Double contrast barium enema, flexible sigmoidoscopy, again, currently infrequently done, not widely available for common use. But that really only leaves 2 tests that we have to look at for screening our patients of these 6, and that would be the immunochemical stool for occult blood and colonoscopy. And these are the most practical for broad-based use for screening in our patients. So you might have patients who fit certain categories who might be appropriate for one of the other options. But for broad-based screening, I think those are the 2 we should be focusing on. So when you're trying to decide what you're going to recommend for your patients, you're going to want to know a little bit about how effective it's going to be in saving their lives and preventing colon cancer. I'm going to try to go through this quickly too. Here you've got mortality reduction, incidence reduction, how often it picks up cancer with one test, and how often it picks up a polyp. And then over here are the stool tests for blood, the short scope, and the colonoscopy. And I think there's some things here that you'll find very interesting. One-time sensitivity for cancer. This is the old Hemocult, 13 to 50%. This is the new FIT test, 60 to 85%. Up to 85% of patients will be picked up with this immunochemical test, much better than that old Hemocult. And when you remember that improvement and you go to mortality reduction, now we don't have, I mentioned before, great studies that show mortality reduction in colon cancer for most of our studies, but we have pretty good studies for the Hemocult. And studies for mortality reduction with the old Hemocult test, the guaiac, show a reduction of 15 to 33%, and probably the 20% range is more accurate. Now, we don't have that study yet for the immunochemical test, but you've seen it's almost twice as sensitive. So you would think that it may be twice as good or close to twice as good. It makes it a very good test. It may reduce mortality by 50%. It's just hard to be sure. Now, this is Lieberman's graph that I've used here. He shows a mortality reduction of 31%. I think that's quite low for colonoscopy. Again, I think most of us think it's around 60%. But a mortality reduction for this new FIT test that's going to be superior to this number is really something that's acceptable. And we should be talking about that option with our patients who aren't going to have a colonoscopy. So a FIT test in colon cancer screening. If we're going to use a FIT test in colon cancer screening, how should we use it? Should we use it up front as a primary choice when we discuss options with patients, or should it just be a salvage for those who refuse colonoscopy? And that's the question, and it's an important question. There's some evidence that might help us make a decision. This is a study done by Johnny Nadami at UCSF a few years ago, and he took 1,000 patients, and he offered 1/3 of them just a colonoscopy, 1/3 a fecal occult blood, and the other third, he offered them a choice. And the results were very interesting. Those who were offered only a colonoscopy had about a 38% chance of getting any kind of a screen done. If he offered the fecal occult blood, and by the way, these were the guaiac hemocults, not the immunochemical one, but I think it's the same message, almost 70% got screened. And then interestingly enough, if he gave the patient a choice between the two, slightly more patients were screened and almost as many colonoscopies got done. So there's something there about giving patients a choice that might improve our screening rates and save lives. So this is another question that's very important. These are patients that we've been following in Nevada in our practice in gastroenterology consultants for a period of 2 years. Over 2,400 patients were studied over this period of time. These were all referred by their primary care doctor for a colonoscopy. Now, of these patients who got referred for colonoscopy, only 60% ever came in for a colonoscopy. That means 40% never got screened at all, and that's despite repeated contacts by our office trying to get these patients to come in for colonoscopy. Now, we're right now trying to study this population more to understand why they don't come in. And even more disturbing, this 60% of patients who got a colonoscopy after they were referred is a very optimistic number, because as you know, those patients in your office, when you offer them colonoscopy, many of them don't even reach this point. They'll already say no. They'll say, no, I'm not going to have a colonoscopy. These patients agreed to get referred, and then 40% of them never came in. So I think the message there is that some patients are just not going to have a colonoscopy when they need one. Now, a lot of those patients might not be saying they're never going to have a colonoscopy. They're probably saying, I'm just not going to have one now. And I think maybe it's financial reasons, maybe it's their schedule, maybe next year they're going to have one, maybe 2 years later they're going to have one. In the meantime, we see all too commonly, while they're waiting, they develop a cancer and they come into advanced. We need to find ways to increase patients who will get screened, and we're trying to do that with this project we're involved in here. So this slide is a published list of possible interventions and their potential impact on colon cancer screening rates. There are some things we can do that make a difference, and some things make less of a difference. This elimination of structural barriers is one of the first things we tried to do with the Nevada Colon Cancer Partnership. And basically what that is is making it easier for patients to get screened. What we've done and what we're trying to get people to be more attentive to, for example, is open access colonoscopy. A lot of patients don't have a primary care doctor. If they don't have a primary care doctor and they need to see a primary care doctor to get screened, they're not likely to get screened. So open access colonoscopy is important, and that's one example of how you can eliminate interactions. One-on-one interactions, as you can see, is very important. High degree of evidence that it'll make a difference. One-on-one interaction is you talking to your patients. Your office talking to your patients, encouraging colonoscopy. Patient reminder is very important. Brochures probably don't make a lot of improvement unless there's a decision aid component. And so if you do have a decision aid, that can be of some benefit. And then group education hasn't been successful. So what do we recommend in the Nevada Colon Cancer Partnership? Well, based upon this, we recommend that at the age of 50, you have a discussion with your patient, and it should be a discussion about two possible options. A test that can prevent cancer, which is a colonoscopy every 10 years, or a test that can detect cancer, which is one of these FIT tests every year. We recommend that patients be given a choice, and that with this choice, we're hoping more will get screened. We provided a decision aid for you that you can use with your patients. Patients can take home with them. And it really outlines the benefits of a FIT test versus a colonoscopy for them. And we hope you'll find it useful. Don't miss an opportunity to screen, however. There are some patients where a virtual colonoscopy or a flexible sigmoidoscopy or some other option might be appropriate. The best screen is a screen that a patient will be willing to have. Something else that came out in the guidelines from 2008 was finally an age limit to screening. It's recommended that if somebody's been getting their screens and they're up to date, at age 75 we should stop if all the screens have been negative and there's no family history. Some patients, for example, if they've been having polyps or if they have a family history, you might want to extend screening up to age 85. In all cases, it's recommended that screening stop at the age of 85. You should consider starting screening on African Americans earlier because they have a higher mortality rate and should start at age 45. We should be using this friendlier small volume prep. We don't want patients out complaining to all of their friends about how bad colonoscopy is, so nobody will show up. And we should all be using the split prep. Every colonoscopy should be done if possible with the split prep because of the improved cleansing and the concern about these flat polyps. So thank you very much for taking the time to listen to the presentation today. I hope that you'll find ways to integrate some of these ideas into your practice. Thank you. So this PowerPoint presentation today is part of a larger effort, a primary care toolkit for Nevada physicians that's been produced and planned over the past 2 to 3 years by the Nevada Colon Cancer Partnership. The partnership is a group of stakeholders throughout the state who have a special interest in trying to improve colon cancer screening rates. And I'm very proud to have been able to work with them over this period of time. And thank you again very much for taking the time to watch this presentation.